providing high-quality outcomes with decreased side effects. We're very, very honored and fortunate to have Dr. Oreo with us, and please join me in welcoming him. Welcome.
Thank you, Mr. Farrington. It's honestly an honor to be here tonight, and thank you for having me. And I think this is such an important topic, and of course, there's been a lot of advances in radiation oncology, and I think it's good to touch base because things do change, and things change for a reason. And I think spending a few minutes to kind of go through them, I think is important. As a disclaimer, I am the president of the American Brachytherapy Society. So when I start to talk about brachytherapy, if I start to get all excited, I'm an enthusiast. I can't help myself. So it's just sort of what it is. So when I was asked to talk about the advances in radiation oncology, I thought to myself, well, that's a big topic. A lot of stuff has happened. But really, can we whittle this down to maybe 3 topics we can chat about? And what I really think is happening is we have a better understanding of what we're treating. We're stratifying prostate cancer at diagnosis so much better than we have in the past through the use of MRIs, refined biopsy techniques, and appreciating that we're a little different in anatomy and anatomic variation. We have image-guided radiation. Turns out the prostate will move a couple of centimeters, an inch or so, in any direction it wants every day. So if you're not paying attention to where it is, you might miss it. And this has allowed us, when we've developed these really precision radiation delivery techniques, to make sure we don't miss. If we miss, we're not going to cure the cancer. Of course, the more dose we give safely, the better off we're going to be. Higher probability of making that PSA go down and stay down. Of course, we want to maximize the therapeutic window, meaning we want to give a lot of dose to the tumor, but we don't want to give dose to normal tissues around it. And there's been some advances, and we'll talk a little bit about that tonight too. All right, here's a secret. We didn't always know what we were treating. So the question becomes, is it time to personalize our approach? And I think that's a resounding yes, because in the past, we've been doing 12-core biopsies. A lot of people in this room have had these. A lot of folks online have had these, but it's a random sample. 12 cores, a couple at the top, middle, bottom, both sides. But what if we missed the tumor because we didn't know where it was? Well, maybe we're working on a diagnosis what isn't truly your diagnosis. So this is where multi-parametric MRIs have come into place. These are becoming very commonplace, and we're utilizing them quite a bit here at Dana-Farber and Brigham Women's because we want to see what's going on inside of the prostate. Where's the tumor? Let's find the tumor. Let's target the tumor. Let's get some tissue from that and find out what kind of Gleason score, what kind of risk of cancer do you have. There's these new staging systems coming up, so if the doctor's talking about or you see this report that says PIRADS, it's basically assigning a score between 1 and 5 of what's the probability that picture that we're looking at, that MRI, actually has cancer. 1 and 2, probably not. 3, I don't know. 4 and 5, probably something we need to go after and take care of. And talking about randomized trials, well, here's one right here. This is how we get all our information. By trial enrollment, we know how to steer the future. And this is why it's so important that as many people as we can get to participate, but here's a multi-center, multinational trial, 500 brave souls have participated, and they're randomized to the conventional trust biopsy, standard of care, or they get an MRI to go see if there was something they should go and biopsy. And they were really looking to see, can we find clinically significant cancers and leave guys alone with elevated PSAs that don't really have much going on, or let's not diagnose a really low-risk cancer, straddle that man with the diagnosis of cancer, but honestly, you probably don't have to treat it because it's never going to be problematic. And by using the MRI first, 28% of patients who had MRIs didn't need a biopsy at all. There were 12% more clinically significant cancers if they did MRI versus the standard approach, and basically 13% less of these grade group of Gleason score 6 cancers, which are probably clinically insignificant, but once you know you have it, you can't forget you do. And so this is where I think we're making some advances, not so much in radiation oncology, but in our radiology colleagues and how we come together with our urologists, because we're taking an MRI. We're finding that lesion which is suspicious. We're using the biopsy techniques that have been used with the ultrasounds and the trust biopsies that a lot of you have, but they're fusing it together so they know where to direct the needle. So instead of doing this systemic biopsy where we might miss this tumor because it's random, we're not looking, whoa, let's put the needle right through it and find out what's actually happening. We have a better idea and we have a better diagnosis which could be made. Because when we're doing this and we're getting the pathology and we're getting that tissue from the tumor, we're trying to assign a Gleason grade, or at least we have been. We're going to be migrating to a new system, which I'll show you, and I think it's important to know kind of some of the lingo that you might hear people talking about. But basically, pathologists would look under a microscope and assign a number between 1 and 5 of how aggressive the tumor was. And they would assign that number to what they saw the most of, and then they would do it again to what they saw the second most of. So you can get a score between 2 and 10. A little bit confusing. So scores of 6 and less were low risk, 7 was intermediate, 8, 9, and 10 were high risk. But 6 to me out of 10 seems pretty significant, and that's more than half. So this was, this is an issue. So the World Health Organization came together and said, hey, stop confusing everybody. Let's simplify this system. It's probably going to be more accurate, and it's a 5-number system. 1, low risk. 5, get ready, we're throwing the kitchen sink at you because we're going to go after this thing with vengeance. But essentially, it's allowing us to have more of a conversation which is a bit less confusing. Grade 1, or group 1, is Gleason score 6 cancer, the low risk stuff we've always been talking about. Grade 2, what turns out to make a 7, you can have a 3 plus 4, meaning 3 is the most that they see, not so bad, versus a 4 plus 3, 4 not so good. So it's allowing us to personalize our diagnosis and the treatment recommendations we make. Then group 4 is Gleason score 8, group 5 is 9 and 10. So Anthony D'Amico, professor here at Harvard, at Brigham and Women's, he really pioneered this sort of staging system, this risk stratification. And basically we're pigeonholing prostate cancer in 3 risk categories: low, intermediate, and high, based upon what a doctor would feel on examination, how high your PSA was, what Gleason score you had. And it worked very well, but things evolve, right? And so now we're really paying attention to how many cores were positive. Was it a 3 plus 4 or 4 plus 3? What was felt? What did the MRI show? Was there cancer going past the prostate? Was there invasion in the nerves? All these different things. So the risk stratification has become much more precise. And when you look at what we're doing here at Dana-Farber and Brigham, we've made a lot of risk categories based upon a lot of different criteria. And this is being done nationally as well. But when we're sitting down with our patients, we have more information. We can have a more informed discussion because we truly have a better understanding what needs to be treated. And then the options which we describe really fit you. This is that whole concept of personalized medicine. All right, let's talk a little bit about image-guided radiation, because this is where I come in. This is what I do for a living. Well, it turns out to image-guide something, you need to know what you're trying to get. You need to know what you're shooting at, what your radiation beams. Well, it turns out we've been planning radiation with CT scans for a long time now, but we're realizing with MRI, it's a much more sensitive and exquisite way of seeing the anatomy of the prostate. So you actually can see what the prostate looks like. It gets a little blurred on CT. And this is a nice little study from Dr. McCaughlin, who basically was showing that we over-contour a bit on CT. Well, that's a problem, because if I'm contouring your bladder neck up high, or your GU diaphragm, where you're trying to keep the urine in your body, and I overdo it, you're going to have more side effects. If I'm treating what I'm supposed to treat, less side effects. And plus, too, I can give more radiation because I don't have to worry about giving the side effects I'm so scared of if I'm not treating the right thing. We also realize we're all made different. Sometimes you have a lot of space between the bottom of your prostate, the apex we call it, and your GU diaphragm. Sometimes you don't. And so you need to appreciate this, because if we're going to give you right therapies and really direct the radiation where the cancer is and where the prostate is, well, we need to know what it is, where it is, and how it may differ. So it also turns out, as I said before, the prostate is a moving target. It moves all over the place. Rectum fills with gas and stool, pushes the prostate. Bladder gets full, not full, could move around the prostate. When we treat our patients here at Brigham and Dana, we basically treat with full bladders, take that out of the equation. We treat with empty rectums, take that out of the equation. Try to keep that as still as possible, but the reality is we still have to localize our target. And so with external beam radiation, we're putting gold seeds, gold fiducial markers they call, but basically they're just gold seeds. I spent a lot of time in the military. If I have 3 points in space, I'm still going to get lost now, but if I had 3 points in space back in the day, I could tell you where I was. I can triangulate. I would know where I was going. Same concept here. We know where we go. So we can change the isocenter so we know where the prostate is, and we can make sure that dose falls on the prostate. We're starting to even invest in MR-Linacs, where we're actually going to do MR simulations to plan the prostate out, but deliver treatment by looking at the prostate real time with MRIs. And this is all coming, it's coming here soon. But, okay, I told you I was the president of the American Brachytherapy Society and I'm a brachytherapy enthusiast. But if you want the ultimate localization, put the radiation right in the prostate. Now, not everybody qualifies, of course, and there's a good discussion you have to have with your doctor, but you have to have that discussion. I find too often men are never told about certain treatment options that exist, and I think that's wrong. I love the slide, knowledge is power. But I always say we have to give our patients the power and the knowledge to make the right treatment decisions. And everything has to be on the table, not just beam or surgery. Well, what about brachy? So indulge me for a little bit as I talk a little bit about that, because to me, it's a wonderful way to make sure you don't miss. It's also a wonderful way to dose escalate, to really get enough radiation in that cancer and that tumor to make sure it goes away and goes away for good. So let's go back to the external radiation. So I do a lot of external radiation too, and it definitely has its place. And we're doing something what's called volumetric modulated arc therapy. VMAT is sort of one of the new things that we're doing in radiation oncology. What does that mean? We're spinning the radiation beam around you in circles, 360-degree circles. We might do it twice. So instead of using the 9 entry points we're doing with IMRT, we're using 720 entry points with different shaped beams so we can avoid stuff we don't want to hit and make sure we get the dose to the tumor, which has been localized, and we take a picture every day to make sure we're going right in the right spot. We can take x-rays to see those gold seeds. We can take cone beam CTs because our radiation scanners or machines now have CT scans built in, which is actually pretty amazing, so you know what you're treating. This is important too because of when we have to treat pelvic lymph nodes, for high-risk cancer, a cancer which has gone to the lymph nodes, there's a lot of stuff now that's going to get in the way. Your bladder's in the way, your intestines are in the way, penile bulb, your hips. We can now start to carve this out so we can give dose to where dose needs to go, but avoid all the normal stuff. And for folks who have lymph nodes which are positive, you know, we're always kind of limited. Well, how much dose can I give to that lymph node because how am I going to see it? Well, if I see what I'm treating before I turn the beam on every single day, I can actually give you extra dose of those lymph nodes because the more dose I give, the higher probability of me killing the cancer or any radiation oncologist killing the cancer. And I just mentioned, you know, the Brigham is making a major multi-million dollar investment in MR-Linacs and MR simulators. So basically using MRIs to plan all the stuff out, and as the radiation is being delivered, having real-time MRIs to see your anatomy, you know, pretty perfectly. And so we're going to be doing a lot of trials, you know, a lot of trials to see how well this works and what kind of toxicities we can do, how high can we get the dose. And so, you know, to be determined, some good data out there, but I hope we're going to be driving a lot of the research in this arena. Okay, let's go back to prostate brachytherapy. So that is when I bring you to the OR, put you to sleep for about 60 minutes, and I put radiation seeds or catheters, because we can do this with low dose rate, which are radiation seeds that go in, or high dose rate, we put catheters in, and the radiation source goes from the outside through the catheters inside, and we take all that stuff out. Let's talk a little bit about low dose rate. So that's why I put the seeds right in the prostate. So prostate moves, seeds move with it. I'm not going through external tissues to get to your prostate. I'm in your prostate. I go through your perineum. So I put a needle in, take a needle out. Super simple. It's elegant. That's why it's so nice, because it's so simple. Needle comes out, radiation seeds stay behind. No cuts, no incision, no bleeding. You're back on your feet the next day. You're in the hospital for about an hour, hour and a half. You wake up, you go home about 2 hours later, and you resume normal activities. So just think, if you have access to cure issues, you don't have a radiation oncology center close by, what a wonderful way to treat prostate cancer, and it can be done in an hour. So things to keep in mind, but I would bet you there's men in this room who have never been talked to about this, and I think that's wrong. And so here I am. So that's what brachytherapy looks like. That's what the doses look like. Green is good, cover the entire prostate. Yellow, hey, spare the urethra. The urethra is a tube that goes from your bladder to empty it, smack dab through the prostate, maybe a little design flaw, I'm not sure, out through the penis. But we don't want to give too much dose to that. So I can start to pull the dose away from the urethra much easier with these techniques where I'm putting the radiation right inside the prostate because I have a little more control of where it's going. Also, too, another advantage is with the radiation from seeds or catheters, low dose rate or high dose rate brachytherapy, the dose fall off is an inverse square, which means that it's decreasing very quickly. I'm losing 20 gray, which is just a sort of radiation number per millimeter, which means I can protect all the surrounding tissues because the dose is falling off very, very rapidly. So I'm not as concerned about overdosing the rectum or the urethra or the bladder. And as such, I can give more dose. More dose I give, the higher probability I'm going to cure your prostate cancer. So we do real-time brachytherapy at Dana-Farber and Brigham and Women's. We have a bunch of centers that do it. We do it here. We do it at some of our satellite facilities. I do quite a bit of it, actually. And with real-time brachytherapy, we're planning it sort of backwards. We're saying we want to get this much dose to this tumor. We only will accept this much dose to these other organs. I bring in a nice big computer with me, which is now about this big, but would be considered a supercomputer not that many years ago. We'll do 500,000 plans to find the unique right solution for you after I contour everything out, spits it out in 90 seconds. I now know in time and space using three-dimensional ultrasounds where those needles have to go. I used to fly airplanes. I helped to do some of the FDA approvals of the system. We made runways. Needle goes on the runway, beautiful. Drop the seeds, take the needle out. If you miss, go around and come back in. But you can have a very precise implant. And the nice thing is we can update as we go along. If we need to put a little more dose, if we want to change some of the angulations, if we want to change where the seeds go, we can do that real time. So it becomes very elegant and very precise. That's what it looks like. This is the high dose rate version where I put catheters in instead of seeds. And a little isotope or radiation source goes in, hangs out at different places, comes out. But it helps me build that dose of radiation that I need to build. Well, I keep saying dose escalation. What does that mean? Give more radiation. More radiation is better if it can be done safely. There are multiple dose escalation, or let's increase the radiation studies, from 70 gray, which is what we could get away with 3D conformal technologies, the older way of radiation being done, kind of when I first started to train, to the 79, 20 gray, or 80 gray, basically, where we really started to really bring up the dose. But in every situation, in every instance, the more dose we give, the higher the probability, big numbers are better, that PSA goes down and stays down, because that's our surrogate for control. There's some mathematical modeling. We get our physicists together, real smart people in a room, and they start to take their calculators out, and they tell us, well, there's about a reduction in biochemical failure by about 1.8% for every 1 gray increase in dose we can get to. Right now, with external technologies, we're kind of pushing the envelope of what we can get to, although there's some products now coming in place which may allow us to keep going. But if we look at some analysis, I always think this is interesting. This is a database analysis, but basically I looked at about 16,000 men or so. For every 2 gray they can give, and these are just radiation unit doses, above 70 gray, there was an 8% reduction in the hazard of death. You live longer, less chance of dying. The more dose we can get in because more cancer we're going to kill. Nice little study that I love to show. Michael Zalewski down Memorial Sloan Kettering, right down in New York City. He convinced his guys to get radiation at different dose escalations, 70 gray, 75, 81 gray or more. And some of this stuff they were just given, but everyone came back for a biopsy about 2.5 years later. To just willingly submit to a biopsy, and you don't even need one, I mean, those are some courageous guys. But he got almost 400 people to do it. But it turns out that the probability of finding cancer after giving just 70 gray is about 51%. It's not so good. Get to 75.6 gray, these radiation doses, goes down to 33%. Once you get to above 81 gray, what goes down to 15%? Not bad. I mean, it's obviously more dose, the better. This is the questions when you're asking your doctor, well, what doses are we going to? What are you going to do? How are we going to, These are fine questions to ask. These are questions radiation oncologists love to answer. I mean, we're all kind of math and science geeks, so just get us talking about dose. We get all excited. But, okay, what about brachytherapy? Listen, I told you you're in for it, but here we are. If we give the right dose of brachytherapy, a good implant, and then do these biopsies a couple years later, the chances of things being positive are down to about 4.4%. For the bad actors, better than 15%. So you can see we can give more radiation dose if we're just putting the seeds or the catheters in the prostate. We also have to pay attention to where the risk of disease is. Now with the MRIs, different scans coming about, we're realizing some guys had disease in their lymph nodes, and that needs to be treated. And as I was saying before, because we can image guide and we know where the radiation is going every day, it's none of this guesswork anymore. We can give more dose to those areas to make sure we eradicate the cancer. And there's also this concept of extracapsular extension. So the higher the risk disease you have, when you get to the high risk categories, there's a high probability the cancer is going past the prostate. I always, I use the analogy in clinic, and I saw a bunch of guys today. I say the prostate's like an orange. You got this thick protective rim, the rind, that keeps everything in. But 22 to 88% of the time in high risk cancer, it's starting to sneak away in this pathologic slide up here, and it's going past. And depending on risk factors, it might be 2 millimeters away, it might be 4 millimeters away. So with radiation, we always treat a little bigger with external beam or brachytherapy seeds. So I say sometimes that's our advantage. A radiation oncologist should put their shoulders back and be proud because we can treat more safely. We're putting up a kill zone around the prostate, so if something is sneaking away, we're going to get it. When the surgeons do their surgery, and surgery is good, and a lot of people choose and do just fine, but they can only lift the prostate out. They can't scoop the tissue around like we do with a breast cancer surgery, take the tumor and a big margin around it. Well, if we did that down the pelvis, bad news, nerves, arteries, veins, you'd bleed, it would be horrific. Can't do it. So sometimes treating more is better. It's not Texas. It's not all the time, and I've lived in Texas for a few years. So anybody out there from Texas listening, oh, I just realized I just insulted Texas. That's a problem. I apologize. Leave me be. High quality radiation. So you got to do it right. If you think there's cancer which is going past the prostate, you better treat it. You better treat it. Because if you're not doing your gentleman any service at all. So pay attention to what you do. But if you're image guiding, one of the big advances of radiation, you'll get it. Neurovascular bundles. This is the nerve-sparing prostatectomy. We want to take it up. We don't want to take your nerves because you don't want to have erectile dysfunction. You want to minimize your chances of erectile dysfunction. Problem with this, though, is oftentimes you can't spare the nerves because you don't want to. The cancer's right there. When you do see cancer, though, near the nerves, if you try to spare things, you realize this is the path of least resistance, so the cancer can kind of sneak away. And so another thing with radiation, we can treat that area. We can give dose to the nerves, but we're not going to destroy them or remove them. So things to kind of keep in mind, especially when the cancers get more advanced, that maybe a radiation approach makes a lot of sense. And we also know one of the refinements is if cancer is going to come back, it typically is where you see it on MRI, a dominant nodule. So if we're doing, say, brachytherapy, I do brachytherapy a lot, I'll put more radiation seeds there. I'll give you a higher dose where the dominant nodule is to have a higher probability of curing it. Curative dose of the entire prostate, I might give 150 to 200% of the dose of that dominant nodule to really just light it up and make sure it goes away. We also have to pay attention to dose painting for our anatomy. The peripheral zone, the portion when the doctors are doing their physical examinations feel, that's where the cancer is about 95% of the time, but it could be elsewhere. But these are things where these are little techniques that we've innovated. By putting on needles or our catheters in, we can start to put dose in areas where we want it to be. So in a situation like this, green is good, treat the entire prostate. That yellow, that red I should say, is about 150% of the dose. That's the peripheral zone. Make sure you take care of where that cancer could be. We might not see it there, but we know 35% of the time if we were to take it out and go look, we might find it, so get it. And then obviously give a lot of dose to the dominant nodule if you identify it and the patient has it. All right, so let's talk about outcomes. This is all pie in the sky stuff, but let's see where the rubber meets the road. The Ascend-RT trial, our Canadians, colleagues did this wonderful trial. They randomized guys with intermediate or high-risk cancer to a year of hormonal therapy. Take away the testosterone being the food source of prostate cancer. It's the fuel, take it away. Then pelvic radiation to get the lymph nodes. And then one group just continued on with radiation just to the prostate to about 78 gray, versus some of those guys, half the guys went and they got an implant. So they put radiation sources right in the cancer to try to really dose escalate. And lo and behold, if you did the brachytherapy, it worked better by about 20%, 25% at 9 years. Looking at controls of 70% versus 93%. Now, not everyone qualifies, but when you do, it's an exquisite way to dose escalate. Same thing with high-risk patients. Brachytherapy got more dose in, higher probability of making that PSA go down, stay down, so you don't have to have salvage treatments, more hormones, pills, God forbid chemotherapy, but salvage treatments. And about 20% difference at 9 years. If this was a drug, that drug company would make billions and billions and billions and billions of dollars on that medication. But I know a lot of men online tonight and even in this room probably haven't seen this data. Probably weren't even offered this as a discussion point. Doesn't mean you have to take something discussed, but sure as hell better be discussed. And I make it my mission to make sure that it is discussed because we need to know our treatment options. Knowledge is power. If you use thresholds of less than 0.2, that's a surgical threshold of success, well, then there's a 50% benefit. Higher probability of getting that PSA way low, stays way low. And just as a comparison, not to beat up on our surgical colleagues who are not here tonight, so that's the best time to do it. But when you have a Gleason score greater than 8, 9, or 10, when you look at the surgical data series, the chances of PSA staying down, staying put, our surrogate for cure, is about 30 to 40%. We see in the high-risk group from the trial I just showed you, our chances of keeping it down are now 83%. That's more than double. Deserves a conversation. I've seen 3 guys in the past 2 weeks with horrific cancers, went to surgery. So much was left behind. Now I'm going to try to go back and take care of it, but now we're stacking side effects. Side effects from surgery, we're going to stack side effects from radiation too. So, personal choices, but informed decision making. Question, 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 question. Don't just take it for granted the guy who's talking to you, the woman who's talking to you in the nice doctor suit and doctor coat is giving you all your options. Press them. Use these support groups to talk with each other and figure out what's going on. Because you have to be your own advocate. Too many times, populations of men, depending on where they are, aren't offered everything. That is wrong. We've got to correct that. Overall survival, no difference at this point. This trial was not powered to say you're going to live longer if I give you seeds. So the critics will say, well, you're not going to live longer, why bother? Well, those guys who've had salvage therapies have been exposed to some of the things that we give to normalize life expectancy. Maybe not so pleasant. Maybe we would like to avoid some of that. All right, so JAMA, the Journal of the American Medical Association. This is the premier journal. Every doctor wants to get their name in this journal. They were looking and comparing radical prostatectomy, external beam radiation therapy, plus brachytherapy. Well, guess what? We got a theme here tonight. So you have 5-year prostate cancer specific mortality, meaning you died from prostate cancer in the high-risk groups, Gleason 9 and 10. Bad stuff. It's about 13%. Same for radical prostatectomy or external beam. Now, I'm an external beam guy too, so I don't want to throw myself under the bus, but I got to be honest, and I try to be honest with my patients. If I sequence a brachytherapy boost in there for you, it drops to 3%. That's pretty good. 13 guys out of 100 dying versus 3. Don't even want it to be 3, but it's better than 13. And obviously you want to be on the right side of those numbers. Distant metastatic free survival. We know prostate cancer likes to go to the bone when untreated or at high risk. Those in this room we're dealing with knows it's painful. It's not pleasant. A lot of therapies we throw at you. Chances of that, 24% with radical prostatectomy, external beam radiation therapy, drop down to 8% if we sequence some radiation seeds or some catheters into that equation. What about living? Well, same theme. About 18% surgery radiation drops down to 10% chance of dying versus 18%, almost half. I want to just take a moment. Peter Grimm, I trained in Seattle, Washington, as Mr. Farrington was saying to you, and this is where a lot of the brachytherapy, prostate brachytherapy kind of epicentered and came to this country. So I'm kind of holding the torch for a mentor of mine who died just 2 years ago. But I believe if you don't forget, you don't die. He was spearheading this conversation many, many years ago. He started this prostate cancer results study group, which I'm now part of, to try to kind of keep that torch moving forward. And he was showing all these beautiful graphs that are accessible, so you could actually understand them in different colors. And this is brachy, this is surgery, this is radiation, high, low, intermediate groups, and how are you going to do? Well, lo and behold, geniuses are ahead of their time sometimes. Any form of brachytherapy compared to all the treatment modalities led to a better, durable PSA control 10 to 15 years after treatment. Now, in the heyday, when this was really being reimbursed well, a lot of guys in this country are getting brachytherapy. Unfortunately, other technologies, doctors get paid more to provide, or have some groups have interest to push you in one way or the other on financial reward. So brachytherapy is not being talked about as much. That is wrong. So we have all these guidelines. We have to tell the doctors, well, how should you treat your patients? And these joint guidelines from the American Society of Clinical Oncology and the Cancer Cure of Ontario, so the Canadians and Americans came together and they said, hey, you know what? For guys, there's enough data now. Guys with intermediate and high-risk disease should at least be offered. Doesn't mean everyone's going to qualify. Doesn't mean everyone's going to want it. But it better be part of the discussion. And it really burns me up to realize it's not part of the discussion, and they had to write guidelines to tell guys, to tell physicians, start talking about it. All right, to end this all up, we've got to maximize our therapeutic window. Fancy way of saying a lot of dose to the cancer, less dose to the tumor. This is one of the innovations. Boston Scientific just bought this company, Agmenix. Agmenix is actually one of your sponsors here tonight, and they made this gel, this hydrogel. So basically a gel that can get inserted between the prostate and the rectum, because one of the side effects of brachytherapy and external beam or any radiation is potentially overdoing the dose of the rectum. So what is it? Myself, a urologist, we will put a needle in, simple, just like doing brachytherapy, just one more needle. It goes in below the prostate, above the rectal wall and the perirectal fat. We have a little kit, gel goes from a liquid state to a jelly state, pushes the prostate up, rectum down. So now radiation dose isn't falling into the rectum. It's falling into the gel, so we're sparing the rectum. It's in the way, move it away. And I can just imagine where this is going to become, I think, an important strategy in radiation oncology, just not in the prostate cancer world. This is where it all epicentered. We're going to see this in head and neck radiation, GI radiation. This is the new wave. Something's in the way, move it out of the way. Simple. You just got to figure out a good way of getting it in, and a lot of studies are being done. And another randomized trial. Phase 3 randomized trial. Guys were either enrolled to get this or didn't get it. And they basically compared outcomes. And essentially, it proved to us that, well, the radiation dose is falling into the gel, not into the rectum. So there was less rectal toxicity. It's one of those things, yeah, no kidding. That would make perfect sense. But you've got to prove it, because otherwise, you're waving your hands all over the place. And they did. And so 1 year post-radiation, space war patients were 46% less likely to experience long-term decreases in their quality of life. Sometimes that can be mucosal leaks, all kinds of stuff. But they did better because we weren't treating the rectum. So here it is. It looks white on an MRI. The rectum is in the orangey thing. Prostate's up there in red. If it's in the way, move it out of your way. All right, my last 2 minutes, indulge me. Setting the record straight. I answer this question each and every day of my life. I want to get a tape recorder because I answer the question each and every day of my life. If you have radiation, you cannot have surgery afterwards. How many guys in this room are told that? Yeah. You probably won't need to. If you have surgery, you can always have radiation after. And guess what? You probably will need to. I'm being a little much. But here's some data from UCLA, Fox Chase Cancer Centers, 2 big cancer centers in our country. They pulled their data, looked at about 1,800 patients who get radical prostatectomy, external beam plus brachytherapy. Salvage local therapies, meaning the cancer came back in the prostate requiring treatment. With brachytherapy and external beam, it's a 0.1% chance. You're not going to need surgery after that, nor would I want to give you surgery. There's other ways to deal with that 0.1, which is minuscule, right? About 2.5% after external beam, but radical prostatectomy in this risk categories, 35% chance you're going to get some radiation to the pelvic fossa, prostatic fossa. Systemic therapies, higher in the surgery group, about 24% of guys needed hormones or something, or some kind of systemic therapy, chemotherapy. About 5.5% with the brachytherapy, 12% in the external beam. And then 10-year prostate cancer-specific mortality. That's just the way of saying, did you die of your prostate cancer? Not as something else, because we're mortal creatures. Other things are going to get us. But did you die of your prostate cancer? Half in the brachytherapy external beam arm, 12% versus 25%. So these are things that we need to pay attention to, and we need to be talking about it. If you get brachytherapy seeds, you're going to be radioactive, and you're going to hurt your grandchild and everyone around you. Nuclear Regulatory Commission basically tells me to treat you like anybody else. You're hard-pressed to find the dose. I mean, you can find a little dose at the abdomen. Tell you not to have a child sit in your lap for about a month. But here's a funny study. These are those things you're like, man, I wish I thought of this. Gentleman, Dr. Mikulski, Wash U, put radiation detectors on everybody, the wife, the dog, the kids, everybody, the walls of the house. And basically what it came down to, the spouse sleeping in the same bed, assuming maybe some sexual intercourse, their radiation exposure through the entire life of that implant was less than drive from flying from Boston to San Francisco. So if you wanted to come home, you'd get twice as much dose. I mean, the higher we go up, the more radiation we get. So obviously negligible. You're too young for brachytherapy. Well, you're too young because you're young and healthy. I'd love to take it out because you're going to heal up pretty well. It doesn't mean you can't have it. I implant a lot of guys my age in their sort of mid to late 40s. A lot of guys won't, but I do because I know the data. If I do a good implant and I keep the dose away from where it's not supposed to go and get the dose where it is supposed to go, and we can do that, it works just fine, and guys do very well. You're going to cause these guys a secondary cancer. Radiation is going to cause a cancer. We have data from, Hiroshima and, some of the war stuff. We know that radiation can cause cancer. We know radiation can cause cancer in the pediatric populations when they're getting radiation therapy for Hodgkin's disease and the like. But when you start to go and look, it turns out when you're in the care of an oncologist, they might say, hey, by the way, you haven't had a colonoscopy. Let's get one of those. But we gave you the radiation first, and now we're thinking about it. Well, then you find this rectal cancer or something that was probably there all along. So if I treat you, I demand you've had a colonoscopy within 2 years because I want to know if there's anything in there, any pathology that needs to be ruled out. I can't tell you how many low-grade rectal cancers I've diagnosed in my 18-year career because it was there. Now, if I gave you radiation, I would have been blamed for that, but it was there. Same thing with bladder. So we did a study, or there was a study done looking at about 230,000 patients. And if you waited and say, okay, the cancer, we had to see a cancer 5 years after radiation, because the window of causing a cancer after radiation is between 5 and 40 years. So you at least have to wait 5 years. The chances of that happening was 0.16% with external beam radiation therapy. There was no excess risk with brachytherapy. Again, we're not treating all over the place to get there. We're planting the radiation seeds where they're supposed to be. I love quality of life data. I get to, one of my roles, I get to negotiate with the government and trying to get costs, kind of this, good for patients, good for us, good for everybody, just to kind of have parity and everything. And brachytherapy actually costs the least. It costs less than active surveillance by about $4,000. It has great quality of life. It's very similar to the external beam, but external beam radiation is a lot more expensive. So, i.e. maybe lucrative at times. Prostatectomy had the poorest quality of life. It was more expensive than brachytherapy and compared to all initial treatment options for prostate cancer. And this is a government sort of group. It's called DICER. They basically, the accountability, they make sure we're doing the right thing. They're saying, brachytherapy was the most cost effective. So you get an effective treatment, it doesn't cost much. And just to end, I really think we need to do these value frameworks. I've been working with some folks at MD Anderson. We're trying to put some of these things together. But basically, we need a very nice way to show you what's going on in a simple way instead of having to read pages and pages and mounds of information, but to distill it down. We know there are different things that are important to people. Would you want to be incontinent or have urinary bladder symptoms, bladder system problems? Is overall survival the most important? Prostate cancer survival, but all this stuff would really just start to compare things in a way that is actually understandable. So we can look at it, we can all be on the same page. So with that, I'm going to stop and ask if anyone has any questions.
I got a couple of questions.
Sure.
With all the advancements now in the new technologies of radiation, can you say that you can start erectile dysfunction at this point in a way? Is there advances in that area?
Yeah, well, that's actually slides I didn't show. So, we have good data to suggest that erectile dysfunction has a higher probability depending on what treatment you have. There's been great articles, but basically prostatectomy, if the nerves are taken out, it's going to be very problematic. External beam radiation therapy, it's okay, but not great. Brachytherapy kind of wins if you can put the seeds in place in the right place. But a lot of this data is difficult because as we age, turns out that's why Viagra, Cialis, and Levitra are a multi-billion-dollar business, because even without prostate cancer, erectile dysfunction happens. But I think you're right. With MRIs, and we're starting to really look to see where things are, we can pay attention to where the neurovascular bundles are, where the prostate's being innervated, and kind of spare our dose. Now, we don't have the data to prove that yet, but I know that's going to be areas of interest because it's an area of research. Because truly, I mean, a lot of the conversations I have with my guys every day is ways to regain erectile function after treatments, any treatments, really. You know, obviously, the less we treat the nerves or the surrogates, these things called penile bulbs, the better off we are. But yeah, I think that's going to be a huge frontier which we're going to be exploring.
My other question is that I had radiation therapy, and no, when I need an X-ray or MRI for something, I'm scared, and a lot of times I would not get an X-ray because I don't want to get much more radiation. Is my thinking right, or does your body repair itself and you can still have those X-rays and stuff like that?
Yeah, no, it's all about cost benefit. So if that X-ray is going to show, you know, something that's going to be helpful for the doctors to make treatment decisions, the dose you're getting for it is minuscule. When you were getting external beam radiation, you basically had the equivalent of 1,000 X-rays, but it was very localized to the prostate to take care of the cancer. So, we try to choose wisely. We limit our the use of scans just to get them. They have to have a medical reason. But if a physician's recommending a scan so they can look into something more, the risk of something bad happening from that, especially in terms of radiation exposure, is so minuscule that it usually makes sense to get the scan.
Right, but my question is that because I had so much radiation, if I get a radiation somewhere, would that mean that part of my body is going to break down because I can't take it?
No, I'm sorry, I misunderstood the question. That's a great question. We don't have lifetime exposure risk when it's we do if a nuclear bomb goes off, there's only so much radiation we can tolerate without getting radiation sickness and having an issue. But when radiation is used medically in targeting things, you can give more radiation to other areas of the body safely. So if you had radiation to your prostate, you could have imaging, X-rays, or you can even get more radiation to God forbid, but other areas of your body need be, without really any consequence that we're worried about. We pay attention to how much dose the bone marrow is getting. We're calculating all that, but it is safe to get more radiation. And honestly, I was showing you some of that data with external beam radiation therapy. We know there's going to be some local recurrences because we didn't give high enough doses back in the day. And oftentimes, I retreat those gentlemen with different techniques and spacers in place to get rid of the cancer. So as long as I can knock away the stuff that I'm worried about treating that has toxicity, you can even give more radiation to the areas you've already had it, as long as it's done safely. Yep. So getting radiation does not preclude further radiation in the future. You just have to, you gotta be thoughtful of how it's done. Welcome. Yes.
Hello? Hit the button. Hello?
Hello.
How you doing, Dr. Oreo?
Hi.
You got a good message there. You got a lot of information. But I'd like to know, do you work in this hospital or you work out of state?
I work in this hospital. My primary position is I'm the vice chair of network operations. So all the radiation which is done outside of this main campus, and we have numerous cancer centers out there, are my responsibility. But I also implant, and tomorrow morning I'll be in the ORs here doing brachytherapy.
Yes, and I also like to know, do you know Dr. Sweeney?
I know him quite well. Chris is a great man.
Yes, that's the doctor that's treating me. And I just talked to the doctor for radiation today, and they set up an appointment for me November 2nd. And what I would like to know is, can you talk to Dr. Sweeney to make sure he's doing the right thing?
You're in great hands with Dr. Sweeney. I love that, though. But I will tell him. Yeah, we went on a little lecture tour together at one point.
Dr. Sweeney is a nice doctor because he geared me in the right direction because so far it's been successful. My PSA was up, and I had 2 shots. I just had my second shot I think this month, and the PSA went down a lot, and but it has a few side effects, and I get hot spells, but excuse me for disrespecting the ladies, I get an erection, but I don't have no semen coming out, you know, so I would like to know what can I do about that. I thank God I'm alive for one. That's what the main thing, you know. But you know, I want to know what can I do about that.
Yeah, I mean, it's definitely consequences of treatment, and we know hormonal therapy, you know, as many men in this room know and online know, I mean, it's taking away your testosterone, which is the male sex hormone, right? The stuff that's been going through our bodies since puberty, and something when we take it away we miss, and hot flashes, decreased sex drive, having difficulties having erections, even less ejaculation. Now, you know, what it is, the prostate actually is a sexual organ in the sense that the prostate makes a fluid that keeps sperm in a liquid state so we can father children. It also makes a energy source, fructose, a sugar. So it, you know, can kind of do all that stuff. The consequence of any treatment to the prostate, being prostatectomy where nothing comes out, or radiation, it's called a dry ejaculation. Very little fluid's going to come out, and unfortunately, there really isn't a whole lot to do about that. That is a consequence of treatment, and that's something we talk about too to our patients, because you know, if you get radiation, sperm can still come out. Fluid from the seminal vesicles could come out, but the prostate fluid, which is about 60%, 70% of the ejaculate, that just goes away.
Yes, but I do get an erection, so, you know.
And use it. Use it or lose it. That's what I tell all my guys.
So they don't have any kind of, like, because the Dr. Sweeney did say if I use some treatment to make the testosterone go up, the cancer could come back.
That is true. So, I mean, testosterone is your enemy in high-risk cancer. You know, I just don't know how it happened, but you know, I guess I was in the military for a long time, and you know, sometimes things are supplemented because you know your job is not to get hurt, right? And you see it. Testosterone will make your PSA go up. You know, steroids make your PSA go up. They can be the fuel to cause a low-risk cancer to go a high-risk cancer. So when a physician's basically saying, you know, we're worried about testosterone, we need to take it away for a period of time. We have to let it go away for a period of time because we know our survivals are increased. It's not the most pleasant thing to have to offer to a man. It's not a very pleasant thing to have to endure. But again, being on the right side of the ground always wins.
Right. But eventually, will it come back once I finish all the treatment or whatever?
Yes, it will. So right now, you're probably getting the shot that he's giving you is probably Lupron. But basically, that shot is...
That's what I'm getting.
It's just tricking your body to think you have too much. And so it's just putting the brakes on the production of testosterone. So once you let up on those brakes, your body will kind of wake up a little bit and your testosterone will come back. I just want to caution, though, by that time, you probably would have had some other treatments, so less is coming out. You know, as a side effect of curing the cancer.
Can you repeat that? What did you say?
Well, less when you have an ejaculation, less fluid is coming out.
Yeah.
Then that's going to be lifelong after treatment.
Oh.
But you have some back because your testosterone will go back, so hot flashes go away, and you know, more energy, you feel a little better.
So now, as far as the radiation.
Dr. Oreo, I had a question as well. I was interested to see the data around brachytherapy, especially the advantages that it confers when it comes to not only, you know, the ability to dose escalate and kind of how it lowers PSA more effectively over time. I guess my question is twofold. You kind of touched on the first one. Why do you think, is there more to why it's not more at the forefront a topic of conversation when it comes to treatment options? And how would you suggest a patient go about bringing this up to their doctor as a potential treatment option for themselves?
Yeah, that's a great question. So I've gone around the country and actually the world, you know, so we're talking about the influences and the factors which are causing a decrease in brachytherapy. You know, one, it really does stem around to a lot of financials. I mean, there are competing treatments which are reimbursed much better. So brachytherapy, you make less. It takes more physician time and more skill set to do. So if you have another option, you might lean to it. There's also been some practices where, you know, groups of people, sometimes urologists come together and buy a radiation machine, and there's data which I didn't show, but the amount of brachytherapy decreases by half the amount of prostatectomies decrease, but the amount of radiation goes up because there's some financial benefit there too. Another study I did is, we're training less people to do it because if there's less money on the table to motivate folks to do it, because it's obviously a surgical skill set one must acquire. We're not teaching our residents because there's not a high enough volume. We have less people going out. So, case in point, the American Brachytherapy Society, which I'm leading, we do these courses all over the country. We'll be doing one in Texas in the beginning of December, where we have teams of physicians coming in we train to teach, knowing they might have missed some of that training in their residencies. It's unfortunate because back in the days when this was a new technology and there was a lot of money exchanging hands to offer it, it was one of the most popular things that men were getting. But, competing technologies, some financial considerations, it's sort of the ugly side of medicine. So what do? You let the doctor you're talking to know you're educated. If they say, well, brachytherapy is not for you, I say that's wrong. You need to talk to a brachytherapist. I just sent out some press releases of ABS during Prostate Awareness Month. We're on PBS. We're doing all kinds of stuff. But if someone who doesn't do something tells you it's not for you, you got to question what they know. And you have to actually be an advocate and demand or do research or contact us. We'll put you to the folks who do brachy and have a conversation with them. And they'll let you know if it's for you or not. But I don't like secondhand stuff. I really don't. And that, I think, is another problem. Because we often say, well, the doctor told me, so I guess I should do it. No. You got to do what's right for you.
I have a question, Dr. Oreo. How often do you use space oil with your patients?
Yeah, I use it quite often in the combined modality setting. So, tomorrow I'll be doing a couple of cases with space ore. When people have had external beam radiation therapy, then I put radiation seeds in. We know the potential for some rectal injury can increase. And we have a product that just basically allows us to take that out of the equation. So I use it quite often in that setting. You're seeing more penetrance. One of the things that was happening in Massachusetts is it wasn't being reimbursed by the government. But it's nice to know that just last week, some of that has been reversed. So it was interesting. There's different Medicare contractors all through the country. There's 7 of them. And the one that covers New England, all the way down to New York, basically said we're not going to cover it. So our population of men really didn't have access to it unless they wanted to pay out of pocket. And it was kind of expensive. But I think that wrong has been corrected. So I think we'll be seeing it used more often. Before it was difficult to sort of say to a guy, I'd do it, but it could be quite expensive. So now that's out of the equation, I think we'll use it a lot more.
Dr. Oreo, I have a question too. Hello? How many organs did you say is being protected with the space ore?
Yeah, so right now, there was primary design to push the rectum out of place. So you get out of the radiation field, if you will. But there's actually some interesting data which is emerging so we know, rectal toxicity, rectal side effects are lower. That's easy. That was what it was designed to do. But there's some information which is coming out now, which is showing that there's less bladder toxicity, like urinary problems, probably because when they're planning things out, they can allow the sort of hot spots of radiation to fall in the gel and not into the bladder walls and things like that. And there's actually some data emerging that erectile function is protected too. And I'm not exactly sure of the mechanism of that, but I think it all comes down to, if you have to spill dough someplace, spill it into a gel. Don't let it spill into a normal tissue or an organ, so.
Okay, and another question, just one other question.
Sure.
I know you're a brachytherapy specialist, but I don't hear a lot of information on proton beam therapy for radiation. Mm-hmm. And I know a couple of people that said that was a good route for them, mm-hmm. but I don't hear a lot about it from radiation oncologists.
Yeah, it's out there. Our national society basically said, hey, put the brakes on this because there's no biological advantage over photons. But the cost of therapy is 5 times as much. And so if you're going to have something that's super expensive, but you're really not providing all that much benefit, you have to wonder why it's being offered. And there used to be 2 proton centers in the country, one in California at Loma Linda, one right here in Boston. And there was 2. And it's really important for kids because you really need to, the radiation will stop, doesn't go past. So if you have a child, you don't want the spinal cord, their eye, you don't want them to go blind. For prostate, well, a lot of prostate cancer. So when the machine wasn't being used for kids, you could use it for prostate. You're getting a lot of money. So those 2 machines went to 28 machines in this country. In fact, I was in Chicago last week, and the government said, I need you to, telling me and my society, because I represent my society, we want you to value protons because so many of these systems have popped up. Some people, it's like everything else. It's another tool in the chest. Some people want that. We talk about it. There's, access issues to it. It's expensive, but we haven't proven it's any better. It's right. It's almost the same biological impact as photon therapy. But it's another option.
Thank you, Dr. Oriel.
Thank you.
Give him a round of applause.